Bonjour à tous.
Bonjour Laureline.
On va switcher tout de suite à l'anglais puisque notre présentateur est anglophone. Donc, hello to everyone for this first Public Health Research Club. We are very pleased to welcome Austin Argentieri for this first one. And I will let Robert introduce him. So if it's okay for you, Robert, you can go.
Yes, but is Austin here? I mean,
Yes,
hi everybody.
here.
Okay, you're here. Okay, I wasn't sure. I didn't see you. Okay, yeah, it's great. So this is. Let me just take a couple of minutes for the general introduction. This is maybe the first session actually of our club, Public Health Research Club between Inserm and the Institute of Public Health at Inserm and IReSP, the Institute of Research in Public Health, which is a funding agency. So we are very pleased to have you, Austin, here with us today. I think the topic is so important. About aging and mortality and what are the determinants, the contribution of both genetic and environmental determinants for aging and mortality. You are in Mass General and Harvard, but I think you collaborated a lot with Oxford on some of these topics, and you also have produced previous results about the proteomic clock and really interesting data seen. I think in general, the looking for new biomarkers of aging is really a very active research field, and it is really critical not only to discover a new one as early as possible, but also to bring them to the clinic one way or another for prevention. We are very much interested in that. In France, we are starting, hopefully soon, a new program on prevention. It includes aging. It's not only aging. It includes part of it is aging, and looking for new biomarkers is really critical. So we are very excited to listen to you today, and I think I'll give you the floor. I will not do much more introduction here. It's just to give you the chance to tell us as much as you can.
So Austin, I will let you share your slide if you want to, or yes. Maybe I can. Yes?
They should be up now.
Yes, it is.
Okay, perfect. All right, well, I can get started then. Well, thank you, Robert, for the introduction. Thank you, everybody, for joining. I'm very pleased to be with you all on the first session of this of these meetings. I'm a research fellow at Harvard and the Broad Institute over over in Boston in the United States. But as Robert alluded to, actually all of this work that I'm going to be presenting today was mostly done when I was over at Oxford in the UK. I did my PhD in a short postdoc over there as well. Let me see. So today I'm going to really talk about one paper that we published a couple of months ago in Nature Medicine on sort of carrying out exposome-wide association studies of mortality, trying to integrate knowledge about both the environmental and the genetic architectures of aging and mortality, and what we can learn about aging sort of as a biological and population process in the course of doing that. I'm really just going to focus specifically on this paper today, although Robert, you alluded to the fact that we are sort of actively working on additional, more sort of biologically focused investigations, things like developing aging biomarkers, proteomic clocks, all these kinds of things. My prepared sort of slides are not going to focus on that necessarily, but I'd be very happy to dive into any of that or dig into it during the Q&A after the presentation. So let me start with a little bit of sort of background and setting the scene for what motivated us to do this research. First of all, there were a few gaps in knowledge that we really wanted to be able to address. At the time when we were working on this, there were very few studies that had systematically identified all of the different environmental exposures that are associated with mortality. There are tons of studies out there that are both small and global in size that look at one or a few or a smaller set of exposures that might be associated with mortality. But we hadn't really come across any, except for maybe one or two much more smaller scale studies that had tried to at one time together, pull together all of the different and map all of the different environmental exposures in one go, in one data set, in one sort of analytic approach that are associated with mortality. And so there have been consequently also very few studies that have comprehensively mapped the environmental exposures that are associated with both mortality and then biological aging. So we're interested in aging more broadly, and mortality for us was just an interesting sort of readout of aging and lifespan. Of course, you can't achieve longevity and long life if you die prematurely, which is what we mostly looked in here. And so to be able to get at more of this, looks like some of my slides were taken away, but let me just put that back up. Should be back on now. I don't know if something's wrong with the permissions. All of a sudden, it keeps trying to take my slides away.
Yeah, if needed, I have them. So.
Okay, it seems like stable for now. In any case,
yes.
What I was saying is that so to be able to get at this more sort of systematic, comprehensive approach to mapping environmental exposures associated with aging and mortality, we moved to the field of exposomics and looking at the exposome, which you can think about conceptually. I'm sure many of you are familiar with this topic. We had a fantastic meeting on this in DC a couple of weeks ago, but you can think about this as, analogous to the genome, right? It's all of the different exposures that we are, all the different sort of factors, exposures that we're exposed to throughout life, whether they're environmental, lifestyle, social, physical, ecological. And so we had a number of different aims that we wanted to carry out and sort of try to investigate in this work. The first was, just simply, let's take an exposome approach and systematically identify all the exposures that are associated with mortality and aging in a single sort of large population data set. And then through doing that, we want to be able to identify what are the age-related mechanisms through which these exposures are influencing mortality. We want to try to find a way to quantitatively estimate the total impact of the exposome on biological aging and age-related disease risk. And then in carrying out all these different steps, once we're able to quantify the sort of total impact of the environment together or the exposome, then we're in a position where we can start to compare for, some of the first time, at least in the context of mortality, what's the comparative or relative impact of the environment versus genetics. We look at common genetic variation in our case on mortality and age-related disease risk. And so let me put this, further now. That's the sort of different aims we wanted to carry out. And let me ground this in the sort of conceptual model of aging we were using throughout all of this work. This is adapted from an article in Nature a few years ago from Linda Partridge. But we have here on the left, the very most upstream influences on this sort of whole cascade of aging and lifespan starts with environmental influence paired with genetics. These then lead to intermediate biological hallmarks and mechanisms of aging. These are well studied and well described. It's an ever-expanding universe, but there seems to be a sort of universal set of biological hallmarks of aging that are shared across many different species, that are also shared across many different age-related chronic diseases. These mechanisms then ultimately lead to frailty, disability, age-related chronic diseases, multimorbidity in many cases, because many of these age-related chronic diseases share some amount of common sort of biological mechanisms across them related to aging. Then these, of course, all together will ultimately lead to changes in lifespan, either premature mortality or longevity. So our aim in this research was to try to capture every step along this causal pathway, going from the first most upstream environmental and genetic influences, all the way to capture the age-related biological mechanisms, the age-related disease risks that follow from those, and then ultimately their effect on premature mortality. So to do this, as I alluded to, we need to take an exposome approach. We need to move from looking at single exposures to looking at all of the exposome together, which will give us a better map of all of the different environmental exposures associated with mortality, but will also allow us to much more reliably map which are the environmental exposures that have an independent, robust effect on mortality when we account for all of the other exposures in our data sets as well. This is what brings us to the exposome-wide association study, going from a sort of similar leap in the field of genomics years ago now, from Canada gene studies to genome-wide association studies, had an enormously beneficial impact on reducing the number of false positives in that kind of population-based genetics research, We expect that moving to exposome-wide association studies and exposome-based studies will have a similar effect in improving the reproducibility of environmental health research more broadly. But there are a couple of challenges that come up when trying to move into this kind of research that are, unique to working in environmental research, some of which are unique to working in environmental research, and some of which are sort of shared among this broader omics work across lots of different disciplines. The first is that we need good replication and validation of our findings, and I think this is an ongoing challenge we have to think about really carefully in the field of exposomics. When we're talking about environmental exposures, we're often talking about observational data. So there's a lot more work we have to do to get to the bottom of possible confounding due to prevalent disease status among those that you're studying. There's a strong amount of intercorrelation between exposures, which leads to a lot of bias and confounding. And there's also all kinds of other residual confounding we have to get to as well. And so a number of the slides I'll go through today are related to the different analytic and sort of computational techniques that we devised in the context of human biobank data to allow us to address some of these challenges and to get at more reliable sets of exposures that might be driving mortality and aging in our case, but these methods I think would apply to, exposome-wide association studies more broadly. Okay, so with all of that set up, let me talk a little bit about the data we use for this. We carried out this research in the UK Biobank. It's a human population cohort in the UK. It's 500,000 participants. They were enrolled in 2006 to 2010. So there's about 15 years of follow-up now. There's genomics, linked electronic health records for everybody, a large amount of questionnaire data and physiological data they collected at baseline, and also some linked measures from geospatial data related to pollution, green space, all these kinds of things. We had a final sample of about 490,000 participants, and the way we structured our research, I'm not touching anything, so I don't know why it keeps taking that away from me. But I'll continue to just kind of...
I don't know what happened, but
I'll continue to just jump back in every time it does it. But I'm not touching the mouse, so I'm not sure why it's doing that. But in any case, we split up the participants. They're recruited from England, Scotland, and Wales. So that kind of gives us a kind of natural way to split them apart into sort of a more discovery cohort and then a validation cohort. So we split apart the participants recruited in England. That gives us our main analytic sample. And then we hold out all the participants recruited in Scotland and Wales from all of the analysis through all the different phases, except for a very final validation of our models at the end. So let's talk a little bit about the study design and the different steps we took to go from initial cohort all the way through to being able to map the environmental determinants of aging and mortality and look at the comparison with common genetic variation. So again, all within the participants recruited in England, we first carried out a discovery and a replication exposome-wide association study, where here it's every single individual environmental exposure associated to all-cause mortality as the outcome using a Cox proportional hazards model and some sort of basic covariates. Even though we do all-cause mortality, the vast majority of the deaths in this cohort happened before the age of 75. And so in reality, what we're looking at here is premature mortality. So if you like, we're looking at essentially the opposite of longevity. So then once we go through that step, we have a number of different exposures that replicate across the discovery and the replication XWAS. Then we have a number of exposure quality control steps. The first is we just do some sensitivity analyses, which are the variables that seem most prone to being confounded by some kind of prevalent disease status. For example, you are only engaging in some kind of activity because you already have a disease and your doctor told you to change something about your lifestyle. That's not what we want to pick up. We want to pick up something that's the exposures that are causing the disease themselves. To further get at the bottom of this, we end up conducting a phenome-wide association study for every single exposure that is replicated in our XWAS. What this allows us to do is map all of the different hundreds and hundreds of variables associated with each significant exposure in our data. And this allows us to look at the patterns from that and see if we can use that to tease out whether there's any underlying or residual confounding in any of those exposures. And we can use that to rule out additional problematic exposures. And I'll go through examples of each of these. Then, since again, ultimately our Our goal is to identify comprehensively the exposures, not just associated with mortality per se, but really driving aging on a biological level. We then look at the association between each of our exposures associated with mortality and their association with a proteomic aging clock that we developed previously and we published last year. And the idea here is if an exposure is associated observationally with mortality, but it's not associated on the biological level with any changes in actual aging biology, it's far less likely that it's having a real causal effect on any of these downstream chains, because for an exposure to be causal to mortality, it has to hit the biology first. So we use that as another filtering step, and then we also do some cluster analyses to get to the bottom of this confounding due to intercorrelation between different exposures in our data. After all of these different steps shown here in this blue box, we then have a sort of final set of exposures that we can say with much higher confidence are independently from each other and more robustly associated with mortality and aging in these data sets. And then we take that final set of exposures and we associate them really broadly to a number of different age-related biomarkers from blood biochemistry panels we have access to incidence of 25 different age-related diseases. And these are diseases that are either highly prevalent in the aging population or that are the major causes of death, the major chronic disease causes of death in the cohort, and a few different cardiometabolic risk factors. And then as a final step, we have these integrative models where we put all of these exposome influences together, plus polygenic risk scores, and we can calculate how much of the variance in mortality and these different age-related diseases are explained by the environment versus genetics. So let's dive into some of the results here. These are the results from the initial exposome-wide association study of mortality. So we're not yet looking at the relationship between any of these exposures, but just at each exposure individually, like you would in a GWAS. We have 164 different variables across different domains of life that both in early life and adulthood that we include as the exposome. But there's a couple of things we don't include as the exposome in this analysis. First of all, we don't include anything related to a treatment of disease, and we don't include anything that might be considered the internal exposome. So we don't include anything like biological changes as a result of exposures or biological readouts of exposures like metabolites or metabolomics or anything like that. We're sticking with the direct assessment of the exposures themselves. We can talk about that in the Q&A, the pros and cons of that, but for this study, that's where we kept things. We have a lot of exposures that are significantly replicated across these. You can see they're colored by all kinds of different domains. And unsurprisingly, smoking, oh geez, I'm really not sure why it keeps doing that. By all kinds of different domains, and smoking comes up as the absolute most important single exposure here. That's shouldn't be a surprise to anybody. But doing this kind of XWAS allows you to, within the context of a single study, start to rank by effect size and significance, which is what you can see here. So another thing that we did was these kind of disease sensitivity analyses that I mentioned before. We did this in a kind of simple way where we redid all of the associations between all of the mortality significant associated exposures. And then we added now in an interaction term between each exposure and an indicator for whether they have any sort of major disease or disability at baseline. The idea here being that if an exposure has a significant interaction with that indicator of baseline disease, but the direct effect of the exposure is no longer significant, then the effect of that exposure can mostly be explained through that behavior or exposure being a result of some kind of baseline morbidity or disability. And so we remove those exposures at this sort of stage of filtering. You can see most of them have exactly the same effect across the initial mortality XWAS on the x-axis and then the sensitivity analysis on the y-axis, but there are a few that we rule out at this stage that you can see labeled here. So now let's get to one of the more interesting aspects of this, which was diving now even deeper into more residual confounding in the exposures. And this was really informative for us and I think is really valuable. And this is really something that biobanks can do really powerfully. But I'm afraid that a number of smaller data sets, you won't be able to do this. We can do this because we have such comprehensively collected information on health across this UK Biobank population. And that was really powerful for us to be able to look at this further. So let's take an easy example. There's a questionnaire item in the UK Biobank on whether you never eat sugar. So it asks, do you never eat sugar? And you can say either yes or no. At face value, you might interpret that as indicative of some kind of healthy behavior. And that's how we were first just looking at it as well. But we started to notice that it was associated with increased risk of disease and mortality and, problematic values of lots of different biological mechanisms. Turns out, if you'd sort of do this phenome-wide association study, the different other variables that never eating sugar is most strongly associated with by far is whether you have a diagnosis of diabetes, whether you're taking insulin for diabetes, and you can see also here labeled up here as well, whether you have some kind of disability. So in actual fact, the effect that we're getting from this variable is really capturing the diabetes and the disability morbidity, and it's not capturing whatever that healthy behavior we thought it might have been capturing at first glance. So we would remove an exposure like this as just too confounded and too problematic to move forward with. And we have a number of other examples of this as well, kind of for those working in the UK Biobank. One that's famously associated with lots of different health outcomes is just asking the participant to count how many vehicles do you have at your household. It's broadly associated with protective effect on mortality, almost all diseases we tested. Turns out if you look more closely here, what this is really picking up is income, whether you live with other people at home, which is really a measure of social support, your population density where you're living. Do you live someplace that's more rural where you have enough space to have a large garage with a number of different vehicles? Do you have enough income to be able to afford having all these different vehicles? Do you not have a disability where you're not able, if you have a disability, you're not able to drive so much. So those people would have far fewer cars. So again, just being able to pick apart from the sort of mass amount of data we have here, the residual confounding in these exposures is extremely informative. This is another exposure that we would have excluded from our analyses, which we would have never been able to find that if we were just doing our normal XWAS. A similar story with frequency of driving fast on the motorway. Again, we see here just an amazing amount of sort of confounding and associations with income, renting low-income housing, being unemployed, having a disability, again, rural population density, just health status rating overall. We would exclude this one as well. So we're able to, through these PHIWAS, really systematically capture all of the different exposures that have too much of this problematic confounding to be able to carry forward with them in any reliable way. There's another one, living home with parents here, but I think I've gone through enough of these examples here. But again, do you live at home with your parents? Turns out what that mostly captures is, do you have a disability, so you have to live at home, or are you unemployed, and are you low income, right? So unsurprising there when you start to see the data like this, but at face value, we probably could have interpreted these exposures as being much different than they really are. So after we go through all these different steps of filtering down and excluding variables, we actually rule out a lot of exposures. When we first carry out the mortality XWAS, we have 95 different exposures that are significantly associated with mortality. After we do the different quality control and confounding, we have only 85 that remain. But the very last step is where we rule out a lot of things. And this is where we look at whether they're also associated with our proteomic aging clock. In these two different columns, you can see here, it's the association between each of these individual exposures and mortality on the right. Red means increased risk, blue means decreased risk, gray means not FDR significant. On the left, you can see each of their associations also with proteomic aging. And what we were looking for is exposures that are associated with both aging and mortality. And pull this back up, that are associated with both aging, proteomic aging, and mortality. Gosh, I just really don't know why it's doing that. And which are associated in the same direction. And that's a really important part of being able to rule out confounding from this as well. Because if something is increasing your risk of mortality, but somehow decreasing your aging on a biological level, to us, that's a big red flag that something strange is happening. And you can see on the bottom right here, there's especially a few related to multivitamin supplement use where there's this kind of bias and confounding happening. And so we would have excluded those as well. So after all these different levels of filtering, we get down to only 25 exposures that remain. But these filtering steps and sort of all the sort of methodological steps we had to take to get to here was probably the most important part of the whole work, because this allows us to get to a much more reliable set of exposures that are independent from one another and are probably much more reliably associated with this whole chain of aging, going from the initial exposure to mechanism to disease to mortality on the same direction. And sure enough, that work really pays off when we get to the next stage. Because what we can see is in this, I'll go through what's happening in all the different parts of this figure, but across the y-axis, you can see all of the different 25 exposures that we identify shown here. On the bottom, these are their associations with incidence of all of the major age-related diseases we studied, with the proteomic age clock, with 3 cardiometabolic risk factors, hypertension, obesity, dyslipidemia, and on the top, all of the different biological age-related mechanisms that we studied as well. And once we get to this smaller set of much more reliable exposures, we see really beautifully consistent patterns of associations across all these different layers and across all of these different steps on the causal pathway that I showed earlier in the beginning slides. So let's just take an example. Across the right-hand side here, we see a nice block or a cluster of exposures that are all associated with decreased risk of mortality and associated with decreased risk of many different age-related diseases, things like education, physical activity, income, do you live with a partner, social support, do you go to the gym, things like that. But not only are they associated with decreased risk of mortality and decreased risk of many different age-related diseases, they're also associated with decreased biological aging, they're associated with decreased levels of these cardiometabolic risk factors, they're associated with decreased levels of more detrimental biological mechanisms and increased levels of protective or beneficial biological mechanisms. And you can see a sort of remarkable consistency across all of these. And this is where all the variable filtering and the exposure filtering really pays off. Because what we're seeing here is essentially the architecture of age-related disease multimorbidity. We're able to find a number of different exposures that are very reliably associated with concurrent risk of all of these different diseases at the same time through this common set of mechanisms that are shared across many of these diseases as well as the readout of aging on the biological level in terms of the proteomic age clock. And these are really fundamental exposures. Things like education, deprivation of the area where you live, your household income, are you employed, sleep, smoking is a huge one, physical activity, social support, psychological well-being. And in fact, 23 out of the 25 exposures that we find, in some way, they're not just really fundamental, but they're to different degrees modifiable as well. Some are much more difficult to modify than others, of course, but all of them are modifiable. Most of them are modifiable. And so what this means is that, thinking about, how can we translate this to levers to address multimorbidity? Well, we have a fundamental set of really important drivers here where if we could just pull a couple of these levers, we're going to see and improve them from a population health point of view. We're going to see a downstream impact on so many diseases at the same time. All of these, look how many diseases each are associated with. From my point of view and from the point of view of sort of our group that was working on this, we chose aging for this reason strategically, because aging on a biological level represents something that's common across many of the major causes of death globally. So if we can find the environmental exposures that are driving that, in our minds, this is the most strategic way to get at what are the absolute highest priority targets for public health intervention and for environmental health intervention more broadly, because effect on one single lever is going to have a really broad, widespread downstream impact on all these different conditions. So that's all of the different exposures independently, but what about all of them together? Well, we find a really interesting thing when we look at the exposome, and that it actually seems to function a little bit like the genome as well. one of the things we've learned from genomics over the last 10, 20 years is that at least when we're talking about common genetic variation, not necessarily rare genetic variation, but common genetic variation or polygenic risk is usually composed of many small additive effects across many different genetic variants that you can add up then to have a sort of significant impact on being able to explain variation in different conditions, especially when we're talking about those who are in the extremes of polygenic risk as well. And it turns out that the exposome does something very similar, where these are all the different 25 exposures that we associated with mortality, plus age and sex. So we can put them all now together in one single model, a Cox model for mortality, and we can now break down how much of the variation in mortality is each of these individual variables explaining. Age and sex do a lot, but what you can see here is a lot of different exposures that have small effects individually, but when added up together, add up to a large amount of variation that we can explain in mortality. So the question is, how much can we explain? And that's showed here, but there's a lot going on, so I'll explain what's happening. But if we just look in the middle here, this is mortality. This is all-cause mortality. So what we find is that when we bring together just age and sex and the exposome together, we can explain almost 80% of all-cause mortality. So between 70 to 77%, depending on whether it was the sort of discovery or the validation cohort. So we can explain an extraordinary amount of mortality just from the exposome and age and sex. Now, one of the things we also did here, as I mentioned at the beginning of the talk, was we want to compare. Okay, well, fine. How much of the mortality variation is explained comparatively between the environment and genetics? Well, there aren't very many good polygenic risk scores for mortality as such. There are a number of technical reasons why that's very difficult. So we took a sort of alternate approach to that, where we instead took polygenic risk scores for all of the major disease-related causes of death in this cohort as well. So in this case, there's 23 different diseases that represent the vast majority of causes of death in the UK Biobank. And we took polygenic risk scores for all 23 of those different diseases, and we put them now in one model for all-cause mortality. And we try to look at how much of mortality can we explain by all of that polygenic risk across all of the different major age-related diseases. Turns out it's not very much. So if we take an initial baseline model where we just look at age and sex in a model and that's it, and mortality is the outcome, we can explain quite a bit. Now, if you add on polygenic risk scores for all of the major causes of death on top of that, the amount of additional mortality you can explain is very little. I think it's less than 1% or only 1 or 2% in our data. However, if you do the same thing with the exposome, completely different story. So you compare a model with just age and sex, and now on top of that, we're going to add all of the different 25 exposures together as the exposome. Now we can explain an additional 17% of mortality compared to just age and sex. So the amount of mortality that we can explain on top of age and sex is nearly 10 times as much for the environment as the exposome as compared to common polygenic risk. And for us, that's really important. And, it should make sense. Human lifespan and life expectancy has almost doubled in many places in Europe in the last 200 years. That's far more quickly than could be explained by, evolution or genetic changes, right? So a lot of people have been theorizing and sort of supposing for a long time, it must be that aging and lifespan are more environmental than genetic, but no one had really done this comparison. And we thought, well, we have a big biobank here. We can probably do some kind of study to try to quantify that. And so that's why we did this part of the study. Turns out we can sort of support that interpretation and that understanding just by looking at these simple ways of bringing together all the exposome. The genetic information had been in use for a long time, but the novelty here is really pulling together all the exposome so we can start to do this comparison between the environment and genetics together. But we didn't just stop at mortality for this. We went further to lots of other diseases. All of the other age-related diseases we studied, we did this for as well. So we take how much of the variation in each of these exposures is explained by age and sex, or by the mortality exposome, or by the polygenic risk score for that specific disease only, if a PRS was available. On the top here in A, you can see across these different combinations of variables, what was the total R squared of these models? So what was the total amount of variation in these diseases we could explain? But you'll also see that on the bottom here, you can see the proportion. So how much of the amount that you could explain is given by each of these three categories of variables. And you'll see the proportion varies a lot across diseases. There are some where it's really big. I mean, for especially the lung-related diseases, COPD, lung cancer, for example, for chronic liver disease as well, we can explain a really high amount of variation in these diseases. And we're doing most of that information is coming from adding the environment or the exposome on top of, age and sex or even polygenic risk as well here. On the other side, there are a lot that are really dominated by genetics: prostate cancer, ovarian cancer, Alzheimer's disease. These aren't too surprising. I mean, we've known this about these diseases for some time, but we're able to sort of confirm it in this more comprehensive way. There are some where we're not getting much information from either genetics or the environment. We're getting a lot just from age itself: osteoporosis, macular degeneration, things like that. So we were able to map and sort of make this sort of bigger, more comprehensive map across all of these. That for us was the sort of real innovation in working on this, to create these comprehensive comparative charts of what's the influence of environment versus genetics, and explaining variance in all of these different age-related outcomes and mortality. So there are some other things we did in the paper. I don't really have time to go through those, but let me just leave you here with a few of the major takeaways that we had from this work. Like I said, environmental factors explain 17% of the variation risk of death, compared to less than 2% explained by common genetic variants. 23 of the 25 independent environmental factors that we found were modifiable, and they're really fundamental environmental factors at that. There were a number of early life environmental exposures. I didn't really discuss those too deeply, but we had a number of them that were very important, including what's your relative body weight or height at age 10. I'm sensing a pattern every time it kicks me out twice. But also whether your mother was smoking around the time when you were born. I mean, these are exposures that have a very reliable effect on aging-related biology, disease risk, and mortality risk 30 to 80 years later. So, the effect of early life exposures can be very reliably shown in the biology and disease risk and ultimately lifespan far later in life, and we should be paying attention to those as well. In general, I think our work highlights or underscores this idea that if we want to study why and how we develop age-related chronic diseases, one of our biggest priorities should be studying the environment. I know that in this day and age, there's a lot of money and a lot of focus on genetics, but I think our work shows pretty nicely that if you want the biggest bang for your buck, if you want a 10 times greater return on your investment compared to genetics, we should be studying key environmental exposures that are influencing these major age-related chronic diseases that are major causes of death globally. So with that, I'll leave also with just a couple of more methodological conclusions that I'd be happy to talk about in the Q&A as well. I think for doing this kind of exposome works, large biobank data sets are extremely useful, and a lot of the analytic procedures that we developed, we probably couldn't have done in much smaller data sets. They allow you to do the systematic testing for measurement error and for bias and confounding. We can really comprehensively test all of the biological mechanisms associated with our key exposures. But there are a lot of challenges that remain. I think number one that I alluded to at the beginning is replication. Every single cohort and every single biobank has a different set of exposures that they've measured, or they've also measured similar exposures in very different ways. So one thing that we have to really wrap our heads around and come to a consensus on in the field is how are we possibly going to replicate these findings across studies? Because I think that's the level of quality of evidence that we really have to hit if we're going to be able to provide the results of our studies robustly enough to be able to convince policymakers, to be able to convince those outside of environmental health. And if we look at omics research, that's the level of evidence, that's the burden of evidence we have to hit. We have to figure out how to get there, whether that's molecular readouts of the exposures or something else. It's up to all of us in the field to come up with. And then as we're thinking about building new data sets, coming up with a consensus on what are the key exposures we should start to measure similarly or the same across all the major new data sets we're developing will be key to helping us solve this kind of problem. So with that, I'll just say thanks to all of my my collaborators and supervisors and mentors on this work, all of whom were at Oxford at the time. One of my PIs at Oxford ultimately moved in recent years back to University of Montpellier. So I'll also thank all of you for listening, and I'm happy to take any questions. Thank you.
Oh, thank you so much, Austin. That was extremely clear and really very relevant. I should have mentioned that we met in Washington, Exposome meeting a few weeks ago, and actually one of the outcome of that meeting was we should do the Exposome at the international level. I mean, it should be a cooperation at the international level, a big initiative like we have done with the genome. So that's
yes,
that's really very relevant. Yeah, there's a lot of questions, and I think Laureline will moderate the question from the Q&A. I just want to add one thing. When I usually talk about mortality and exposome, etc., I show a picture from WHO where air pollution is at maybe the top priority, like smoking, almost the same level as smoking. I haven't seen that much, of air pollution in your data. I mean, how could you explain that?
There's a few possible ways. We did have sort of pretty good resolution to air pollution across a number of pollutants in the UK Biobank at multiple years of collection based on postcode mapping. And so they were included in all the initial analyses, but they didn't survive all the different steps. And where most of them end up filtering out is at the level of they're not associated reliably with the biological aging clock. So there is this question of, because we're not, I sort of mentioned this at one point, but we're not studying all exposures with any relationship to mortality. We're only trying to find the aging-related ones. Yeah. So we talk about this a little bit in the discussion of our paper. It could be possible that they're very relevant for mortality, but less relevant for aging per se. But I still think that needs to be, this is our work, I don't think is the definitive guidebook of these are all the exposure. I think our work is hopefully just the initial catalyst for people to do a lot more stuff like this at even bigger scale to come at bigger consensus. So there's, I think even on the aging biomarker side, there's a lot of room for improvement there. And I glossed over this detail, but the sample size for the proteomic age clock analyses is much smaller. We only have proteomic data for 45,000 participants. So for some exposures, we may have less power than in the overall XWASP, where we're dealing with almost 500,000. So all of these things, I wouldn't take our results as definitively air pollution doesn't matter, but just in the way we did it here, that's what happened.
Okay, thank you. Laureline, you will moderate the questions?
Yes, okay. I have a few that I can ask now. So the first question was, can UV exposure be considered part of the exposome?
Definitely. We just don't have a direct measure of that in the UK Biobank. We have indirect measures of it in terms of how easily does your skin tan and how much sun protection do you use. And the skin tanning measure comes up as one of the final exposures that we identify, but we don't have a direct measurement of UV exposure. So that's one of the problems of doing it in all these data sets, is that we have completely non-complete, entirely non-complete representation of the whole exposome. It's just what we have access to that was measured.
Thank you. The second question was, the exposure could evolve across time. How to capture that?
That's a great question. And another limitation of this work is that we really only have comprehensive assessment in the whole 500,000 people at one time point at baseline. So one of the things we can't do is that kind of looking at the time dynamics of exposure and how that influences. So we just need better data sets that have more, that can pair all of the sort of comprehensive health information that we have in this kind of biobank with repeat assessment on the exposure sides. I know that there are a few data sets in Europe that have some more things like this. Some of the birth cohorts also have better sort of repeat assessments as well. I know there's the ELSA cohort that has repeat exposures. So it all comes down to data, I think, and we just need better data sets, and then we need, but there are a number of analytical methods that we already know of for analyzing the actual time varying exposures. We just need to bring all the data together, and we didn't have it here.
Thank you. How to analyze the impact of environment shocks, such as hurricane? Are they included in stressful life events?
They're probably important, but they're just unfortunately not included in the UK Biobank. I think that's going to be a common refrain across many of the answers to these questions, and it gets at the heart of that key challenge that I mentioned at the final slide. There's a lot of stuff we wish was measured in the UK Biobank that it's not, and there's a lot of stuff measured in the UK Biobank that's not going to be in another one and another one. So this is just a huge problem. And of course, that will also start to be geographic specific. Some geographic locations are going to be way more vulnerable to that kind of sort of environmental weather-related trauma than others. So that's another thing to mention about everything I showed here. This is in the UK. This exposome for mortality and aging there might not apply somewhere else. And so, I think what we're going to need to develop are these kind of global maps that can do this on a more local level. But to answer the question more directly, we didn't have it measured in the UK Biobank, so I couldn't tell you for these data.
Thank you. And why not using propensity? I don't know if I pronounced so well. Score matching combined with machine learning methods, random forests.
So we developed the analysis techniques for this almost 5 years ago, maybe almost 6 now. We have since been working on ways to do these exposome-wide association studies using machine learning models instead, which I think can account for a number of the different steps in one. Our model architecture of choice is not necessarily random forest, but we do like to use gradient boosting models, which are in the same family of kind of tree-based machine learning methods. So that's an area we're looking into now, but just 6 years ago, we didn't have that expertise to pull those in, but I would say, yeah, absolutely. And some of those machine learning models, as we can feed more and more data into them, might also help us with the sort of confounding piece with understanding maybe possible causal relationships. The nice thing about the machine learning models as well is that they natively account for interaction between all of the exposures themselves as well. And obviously our Cox models can't do that unless we model a specific interaction for everything. So I agree with you, that's the way to go. It's not in the future, just not how we initially devised it all those years ago.
Thank you. Do you think that this exposure perform the impact through modulation of gut microbiota?
Could be. We just, back to the common refrain, we just don't have microbiome information in the UK Biobank. So, I think view our results as a challenge to all of you to now take these exposures that we found and go to your data sets where you have the microbiome information, where you have the other information on other environmental assaults or other layers of biology, and build out the picture there of all the other layers of biology they might be associated with. We went comprehensively across everything we had access to at the time in the UK Biobank. So, if you didn't see it in the slides, the 95% chance it just wasn't available in the data set. But
okay.
Don't take our study as the be-all end-all final, we've mapped it all. Just take it as the challenge to go map it even further and take those exposures as key priority ones, and let's further map out the biology related to those.
Okay, maybe it has already been answered, but did you look at the potential interaction by gender?
Yes and no. I didn't mention this at all, but we initially, and I didn't show a slide on this, but it is in the paper. We initially ran the XWAS separately in males and females. And then what we did is we looked at the correlation between the sort of effect estimates in the male XWAS for the same exposure and the female XWAS. And they were so almost perfectly correlated that for the set of exposures that were common across males and females, we sort of concluded that they were capturing very, very similar effects and that we could just pool them together to get better sample size in the XWAS. There are pros and cons of doing it. That we decided to go that route because we just saw, gosh, I wish I had a slide on that, but it is in the paper, either in the main paper or in the supplement. You can see the comparison of the effect estimates for all the exposures in males and females separately on mortality, and they're almost exactly the same. The trade-off of doing that, however, is that we do have a number of male and female specific variables in the UK Biobank that get dropped out. They're mostly related to reproductive activity and puberty timing. But that was a compromise. But we did bring those all back in the final analyses where we looked at a few diseases that were sex specific, so like prostate cancer, breast cancer. For those, we brought back in all of the, male or female specific exposures. But otherwise, we didn't see enough of a difference in the effects to warrant keeping everything sex stratified throughout the rest of all the downstream exposures. But sex is certainly added as a covariate to all the analyses.
Laureline, we missed a question from Archana about...
yes, I was.
I wanted you to...
Okay. The question was, exposome boils down to social determinants.
It's a question.
Does it boil down to social determinants?
Yes.
No, I don't think so. It may seem that way from our research, but that's because the exposures that we had to start with to analyze are so heavily biased towards that direction. And we're missing a ton of exposures on the chemical, toxicological side. So I wouldn't want anyone to take that away from our research, but what our research does underscore is how profoundly that those social determinants of health do matter. I mean, we can compare the effect size and the significance across these, and some of these social determinants are there, in the neighborhood of effects as smoking and all these things. And, when you talk to most people who are outside the sort of social determinants of health arena, they're always really skeptical. Oh, well, maybe they have some small effect in this study or that study, but it's all going to be drowned out by smoking and explained by smoking anyway. When I was at Oxford, I was in the population health department there, and I got that criticism all the time. And so that was our challenge for this paper. And that's one of the values of doing the exposome-wide association study, because everything is done in the same way for all the exposures, and you can rank them and you can look at them all, and the social determinants of health hang in there with all the rest of the really major powerful ones. So I would say our work underscores how powerfully important they are and how broadly they influence so many different things. So if we can fix those, we're going to have a huge knock-on effect on lots of different diseases at the same time. But we were just missing so many physical, geographical, chemical, toxicological exposures that we just had way more representation on the social and lifestyle side. So that's why you sort of see that imbalance there.
Thank you. I have a few more questions. So do you investigate if the results are sensitive to a healthy individual participation bias in the UK Biobank? And there is a comment, many PRS are likely correlated with the exposome so hard to interpret when in the same model.
We did not really look at the interaction between any of these exposures and participation bias as such. Part that I glossed over completely, although it was there in the sort of study design slide, is that we run a sort of multiple